Well, thank you all so much. Thank you, Andrea, and thank you to Sue. And thanks, everybody, for coming out today. This is a great crowd. I really appreciate your coming. My name's Tim Baxley. I'll talk about stroke. This is a lay lecture about stroke. And I want to attribute nurse practitioner Pepper from Providence Hospital for much of this lecture. We'll talk about stroke. The way to think about stroke is really as a brain attack. We talk about heart attacks all the time. When the heart doesn't get enough blood flow, the tissue dies and the person has a heart attack. It's an emergency, of course. It's a medical emergency. But we should think the same, we should be thinking along the same lines with the brain. Stroke actually is a brain attack. And this introductory slide actually shows a beautiful picture of what happens. Most of you can see it. There's a second screen as well. But here's the carotid artery going up into the brain. A cholesterol plaque is formed. And so the blood is not getting to the brain, and then there's a stroke developing. So that's a brain attack. That's a stroke. It's a medical emergency. Some of the objectives, we'll talk about what a stroke is. We'll list the different types of strokes, some of the risk factors for stroke, things that we can and can't do anything about, and then we'll talk about signs and symptoms of a stroke. And by the way, these slides, the edge of the slide, every one of these has a little algorithm that you can run through whenever you think a patient is having a stroke. Ask them to smile. It should be nice and symmetric. There shouldn't be any drooping of the face. Have them raise both arms. There shouldn't be, one of the arms shouldn't drop. It can be a sign of a stroke. And then ask them to say a sentence. Like, the sky is blue in Boston. You want to make sure they're not having any slurred words that could be suspicious for a stroke. So we'll leave these up with every slide. So a little bit about stroke statistics. Stroke's the number 3 cause of death in the U.S. Behind heart disease, which is number 1, and then all different types of cancer combined are number 2. Stroke is a close third. 160,000 Americans die every year from stroke. Every minute, somebody in the U.S. has a stroke. There's about 800,000 strokes a year in the U.S. So what is a stroke exactly? We already talked about it's similar to a heart attack because tissue's not getting the blood flow that it needs. A stroke is when the brain tissue's damaged from loss of blood flow, and that results in a loss of function. There are 2 causes. One is a blockage. That's a typical stroke that we all think of, but another less common is where the blood vessel leaks or bursts, as in an aneurysm. And we'll talk about that. There'll be some examples. So when we talk about a typical stroke, that's where the blood flow is limited going into the brain. That makes up about 85% of all strokes. This is a little bit difficult to see, but here's a beautiful picture of what happens. Here's the blood flow going up into the brain. There's a cholesterol plaque that's built up in the artery. Blood's trying to get through, but it's blocked. So everything downstream of that artery is going to be without blood flow. So that's a stroke. It won't be functioning. That's the most common type of stroke. The second most common type is actually a brain hemorrhage, where the blood vessel actually bursts. And you can imagine that's catastrophic. Anytime there's blood under pressure, arterial pressure going into the brain, that's a serious stroke, the worst kind to have. High blood pressure and smoking are the 2 big risk factors for that type of stroke, and the regular types of stroke as well. We talked about ischemic strokes, the so-called regular type of strokes. That's 85% of all strokes, where there's 2 types of those. One of them is when an embolus, which is a piece of blood or cholesterol that travels through the body. An embolus may travel up from an artery or from the heart itself and go up to the brain and cause a stroke. The second one is thrombosis, where you have a plaque, cholesterol or what have you. Gradually it builds up and closes down until the artery is completely closed, and then there's a stroke. That's the most common type of the ischemic strokes, is the thrombosis. Now the hemorrhagic stroke, which is less likely, we talked about smoking, high blood pressure are the big causes of that. That's when a blood vessel actually bursts in the brain. There's another risk factor for that too, people who maybe have an aneurysm, or there's a weakening or a ballooning of the blood vessel. If you have that in a smoker with high blood pressure, you're really asking for trouble. So there's risk factors that you can and can't control, which we'll talk about. Smoking and blood pressure are two biggies. You've all heard of a TIA. It's called a mini stroke. A lot of people will refer to it as a mini stroke. It's a stroke-like event that lasts less than 24 hours. So somebody may be completely weak on one side. They may have the facial droop we talked about, decreased sensation on one side, but it goes away after 24 hours. That's where the stroke starts to develop. The vessel's getting closed off, but for whatever reason it reverses, thank goodness. Some people say that because the TIAs or the mini strokes don't result in permanent brain damage, it's not really a big deal. But it really is. They're very serious, and anybody with a TIA or a mini stroke should be admitted to the hospital. And the reason is a third of those patients will go on to have a bona fide stroke. 5% of those strokes will occur in the month after the TIA, and half of those, 2.5%, will occur in the first 2 days after the TIA. So if you know somebody who's had a mini stroke or a TIA, they really need to be in the hospital and be observed and have some testing done that we'll go over here in just a minute. So the stroke risk goes up after a TIA, absolutely. So really all ages, all races can have stroke. We see strokes in children sometimes, although stroke is definitely in the older you get, the more risk there is for stroke. So signs and symptoms of a stroke, we've already touched on a number of these, but sudden numbness, weakness of the face, arm, and leg on one side of the body, confusion, trouble speaking, trouble seeing in one or both eyes, dizziness, sudden severe headache, and the key word in all of these are sudden. It's a sudden onset of any or all of these symptoms. If somebody has migraine headaches, they develop their typical headache. It's not a stroke, but a sudden severe headache, which is new. It could be a sign of that hemorrhagic stroke that we talked about. Most strokes don't cause pain in the head, but the exception is the hemorrhagic strokes that we talked about, where the blood actually goes into the brain itself. You know, strokes, if somebody has a stroke on the left side of their brain, it'll affect the right side of the body and vice versa. And the reason is this: those neurons cross over in the brainstem. So here's a person from the back. The left side of the brain controls the right side of the body because of that crossing over. Okay, here's some risk factors that we'll talk about for stroke. Some of these can be controlled. Blood pressure, smoking, even secondhand smoke. Are you exposed to tobacco? You know, a smoker or secondhand smoke. Overweight, diabetes. You can't choose to be diabetic sometimes, especially type 1, but you can certainly modify the blood sugar. There's ways to do that. High cholesterol. Those plaques we looked at earlier, they are cholesterol in the body. You know, that's why we try to decrease the cholesterol, because it will close off the arteries and cause a stroke, heart attack. The limbs can get no blood flow. Heart disease is a risk factor for stroke. And then family history of stroke. If you exercise less than 30 minutes a day on most days, so 4 out of 7 days. You want to do something that gets your heart rate up. You can't really control that risk factor if you've got a family history of strokes, and there are some genetic syndromes that cause strokes. And then men over the age of 45, women over the age of 55, there's nothing we can do to control that, but the rest of these risk factors we can certainly modify. Physical activity is a biggie. And just because you're at risk for stroke doesn't mean you'll have one. We already talked about the risk factors that could be controlled and not controlled. Diet, exercise. You want to do something 30 minutes 4 times a week. And you know, your maximal heart rate, by and large, talk to your own individual doctor about this, but 220 minus your age is supposed to be your maximum heart rate. Now, your target heart rate for exercise is 220 minus your age times 0.7. So you want your heart rate that high for 20 to 30 minutes, at least 3 to 4 times a week to get the benefit. So there's a maximum heart rate, 220 minus your age, and your target heart rate for exercise, 220 minus your age times 0.7. Smoking is the big one. Medications. Got a lady just up, I just saw her a few minutes ago. She's supposed to be on aspirin for her heart. She hadn't been taking it. So now she's had a stroke. And so, you know, that was a big risk factor that she could reduce, is taking her medicine in the right way. Now, the different regions of the brain control what the stroke syndromes are. Most of the strokes are in the frontal lobe. That's the so-called typical stroke, where somebody has a stroke, say in the right frontal lobe. The left side of their body's weak. So the frontal lobe controls strength. Parietal lobe is sensation. The right parietal lobe controls left-sided sensation, and vice versa. Occipital lobe has to do with vision. Some strokes can cause blindness if the occipital lobe's involved. And then the temporal lobe has a lot to do with heart rate and autonomic functions, blood pressure, etc. Cerebellum, the back of the brain, has to do with balance, coordination. Then the brainstem itself has to do, again, with autonomic functions like breathing and blood pressure control. So strokes are definitely an emergency. That's why we're starting to call it a brain attack, just like we talk about heart attacks. When you go to the hospital, you'll have some tests done: CAT scan, EKG, carotid ultrasound, echocardiogram. In the emergency room, we like to use CAT scans. They're a lot faster than MRIs, and we're worried about blood in the brain. You remember that 15% are a hemorrhage, and an MRI can sometimes miss blood in the brain. So ER doctors like to get a CAT scan. It's a lot faster, 5 minutes as opposed to 30 minutes. If you're having a stroke, you don't want to have to lie flat and lie still for 30 minutes in the MRI. It could be dangerous. So we prefer to do a CAT scan of the brain immediately when somebody presents to the ER with a stroke. Here's a picture of a lady who's having a stroke in the left temporal lobe. This is actually an MRI, but it shows up beautifully on this image. So this person is a dominant temporal lobe. She might have problems with her heart rate or autonomic function, blood pressure control. We want to do an EKG with all stroke patients because, you know, the heart's supposed to beat regularly, receives blood from the body and then pumps it out just regularly. Well, if it's not regular, it's irregular, and a heartbeat is not coordinated, then blood can actually pool in the heart, form a clot. That clot can break off and go to the brain and cause a stroke. So that's why atrial fibrillation, the average patient with atrial fibrillation has about a 4% risk of stroke per year. So that's why a lot of those patients are on high-powered blood thinners like Coumadin. And that's why we always have an EKG done for stroke patients in the hospital. The carotid ultrasound, it's just sound waves that we use to check the blood flow in these arteries going up into the brain. Here's a picture of what can happen. Here's the carotid artery. There's a blockage right here. You can see beautiful blood flow here up until you get to the point where there's a blockage, and then there's minimal blood flow upstream from that. So that patient's either having a stroke or about to have a stroke. By the way, this would be a situation where an interventional doctor could go in with a stent and maybe put a stent right there, go up through the groin, through the heart, up into the artery, and actually put a stent right there and take care of that. And they're starting to do that in some stroke centers. We look at an echocardiogram looking for that clot we talked about. If there's a clot in the heart, the echocardiogram just uses sound waves to pick that up. If there is a clot there, then again, that person might need to be on a high-powered blood thinner like Coumadin. Chest x-ray, that's not as important. Now, blood work, whenever somebody presents to the ER with a stroke, we look at their blood work. We want to know what their sodium is, their blood chemistry, their glucose is, and then we're also looking for cholesterol. That's the biggie, because we talked about those plaques. They really are cholesterol. So, we talked again about the symptoms of a stroke. This is what, have the person smile. Should be nice and symmetric. There shouldn't be any kind of asymmetry. Have the person raise both arms. If one arm starts to drift, then you worry about a stroke on the other, in the opposite side. And have them say something, and they should be able to speak clearly. So stroke's a medical emergency. We have about 100 billion neurons in the in the adult human brain, 100 billion. The neurons are the nerve cells. They do all the work. Once somebody has a stroke, they lose 2 million neurons a minute. And so if you let it go on and on and on, it can have a catastrophic outcome. That's why these people need to be in the emergency room right away. This is a big reason because of that TPA, which is a so-called clot-busting drug. Here's a picture, blood flowing downstream. There's a clot. It can't really get upstream. That TPA can be given in a peripheral vein. It travels to that site and can break up the clot and restore blood flow. But there's a lot of exclusion criteria, so you have to be very careful administering that drug. You really have to get to the hospital within 60 minutes. The window to use TPA, the clot-busting drug for stroke, is 3 hours. But by the time people get their blood work, their CAT scan done, it's read and interpreted, you really need to be hitting the hospital within 60 minutes from onset of symptoms. There's other medications used for stroke. Of course, aspirin, Agranox, and Plavix, they all thin the blood. They make the platelets less sticky, so when they're trying to get through an occlusion, it's easier for them to get through. Blood pressure medicine, we talked about high blood pressure is a major risk factor for stroke and heart attack. And we talked about compliance with the medicine. That's a risk factor you can modify. And then cholesterol medicines. A lot of people say, I can't take cholesterol medicines. They're talking about statins. I just can't take them. They make me sick. They make my muscles ache, and they hurt the doctor said it was hurting my liver. All right, well, there's other things you can take for cholesterol besides statins. Things like some of the B vitamins, like niacin, fish oil. So there's other medicines that are there's other dietary medicines that can help your body get rid of fat before it's even absorbed. So just because you're intolerant of a statin doesn't mean you can't take a medicine for your cholesterol. We'll have physical therapy involved once a patient's admitted for stroke, because if you take even a healthy person, 60 or older, lay them in their bed for 2 more days, for 2 days, they'll lose 50% of their strength. And not to mention if somebody's got diabetes, had a stroke, other problems going on. So the physical therapists here do a great job of getting patients up, out of bed, into the chair. And that helps the lungs expand. Stroke patients will get a pneumonia because their swallowing is not coordinated. Even if they're not being fed, they will get pneumonia from their saliva not being processed properly. So these people have to get up, get in a chair. Speech therapy has to see them. And there's a lot of things that have to take place after a stroke. We'll try to get a patient to a rehab center. A lot of people don't want to do that. They want to go home. But the statistics show that people improve markedly more if they will go to a rehab center and then just take that couple of weeks to get the rehab started and then go home. And there's discharge planning. The patients will make sure the family has everything they need for when the patient does go home. That's important, and the Baptist Easley Hospital does a good job at that. So the take-home is what we talked about as far as spotting a stroke. You know, have a patient smile, should be nice and symmetric, their hands shouldn't drift, and then they should be able to say a sentence appropriately without slurring their speech. If any of those are taking place, and I'd call 911 because that is an emergency. That's a brain attack. Well, thank you all very much. Now, I'll be glad to take any questions.